Good afternoon, everybody, and welcome to today's Wednesday round session. I would love to open us up with a little bit of housekeeping, and then I'll introduce today's speakers and frame up the talk for the hour that we're walking into. The first thing is thank you so much for being here. I am delighted to see so many faces in the room, and I know we have many online. At the conclusion of today's session, you will see behind me a QR code to complete an evaluation for today's session. Please do that. The evaluation does a couple of things. One, it gives us important feedback about the speakers and the series and today's talk. We do share that feedback with the speakers when they come, but it also ensures that you get continuing education credit. And so if that's important to you, you'll want to be sure that you complete it. For our friends who are online, you'll need to have attended for at least 45 minutes to the session in order to get credit, and then you'll be emailed a link to complete that evaluation. What else do I usually say in housekeeping? Okay, that's it. That's all I have for housekeeping. But I am delighted to introduce today's speakers for our Romano rounds. To my left is Julie Achtyl, the psych therapist chief for the department. It is a relatively new role, and she is absolutely crushing it. I won't go into detail about that. But in that role, she has primary oversight of the mental health counselors, marriage and family therapists, creative arts therapists, peer advocates, CASACs, rehab therapists, seriously? Recreational therapists, employee assistance program counselors, and clinical evaluator disciplines. For anybody in those disciplines who's interacted with her, you would know what an exceptionally strong and thoughtful and sensitive leader she is, but there's more. Prior to assuming this role, she has had actually quite a bit of clinical and leadership experience here in our department, predominantly at Strong Recovery, where she spent over 18 years serving as a leader there, and most recently was the co-director of operations. As it relates to today's talk, she has been a very staunch advocate for peer services and ensuring that we have an adequate interprofessional and diverse team in order to address the varied needs of our patients and community members. She also happens to be finishing her PhD in counseling and counselor education at Warner. You do all of that. It's kind of amazing. Also to my left, but to Julie's left, is Dr. Anne Marie White, who's an associate professor of psychiatry with secondary appointments in public health sciences and community health and prevention. In her university faculty roles, she leads change initiatives to deepen community engagement and public health approaches to health promotion, as well as child development via service, education, and research. She founded the Office of Mental Health Promotion here in our department and has led in the nonprofit sector. Over the course of the last 2 decades, the Office for Mental Health Promotion oversaw community, consumer, and diversity affairs for psychiatry faculty and staff. Dr. White now directs collaborative and participatory research and teaching within the undergraduate public health program. She is a staunch promoter and supporter of mental health supporting behaviors, services utilization, injuries, prevention, as well as child and family development strategies, all within community-based settings. Her research applies systems and data science methods in community-engaged research, mental health promotion, did I say that already? Yep, and injury prevention systems. And her years of research and administrative experience and leadership relative to developmental psychology all emphasize the role of community engagement, community settings, particularly like childcare, schools, art centers, and after-school programs. Is that an okay place to start? This is an amazing team. I'm very excited for the session that we're walking into, partly because I think there is so much that so many of us in the room really would benefit to know and understand about the role of peers in our department. And I can think of no better people to introduce us to that, as well as this panel of experts here to my right. And without further ado, I'm going to raise the podium for Dr. White. Is that good? I do love that. I do love it. That is inclusion. I've said it before. I'll say it again. I love it.
So good afternoon, everyone. It truly is an honor and a privilege to be standing here on behalf of these amazing panelists to be presenting to you today's clinical rounds entitled Power of Peers, Lived Experience and Hope Leading the Way. So, okay, it's all working, great. So the speakers today, we have no commercial financial disclosures. And I would just like to provide a little bit of background in terms of how we got here and people we'd like to thank for being here today. So Julie and I would really like to thank Sue DiGiovanni, Rob Weissman, Anna Kedley, Marilyn Guadagnino, and Richard McCory for their input and support that led to today's grand rounds. A year ago, I'm looking over at George Nazara. I was sitting in George's office and really waxing on about the power of peers and really how we are at our best in providing health when we integrate peer services. And really, time and time again, I see how we're at the top of our mission in doing so. And being an academic medical center, how important it is to be integrating scholarship and advancing the scholarship of peer-to-peer support as a public health practice. So through that set of conversations, Julie and I started meeting, and I was able to speak to over 6 of our peer supervisors and peers in providing services across our department, and immediately heard an appetite from everyone I spoke to around doing a grand rounds. So we want to thank again everyone who's contributed to that and made today happen. The goals for today are really defined by all the panelists here. Our objectives are to really share with you the roles and see the roles across all our clinical services, our emergency services, our outpatient, our inpatient, and to contextualize that in our broader local and national context of peer services, to be highlighting some research and some data about peer services, including in our own system, and certainly as a clinical rounds to be sharing stories that really illustrate the collaboration of peers with other providers and also with patients that do bring hope to both patients and providers. I'm going to hand over to Julie now, who's going to finish introducing and then get us centered on some key definitions.
So while Sean is helping us, I just want to share just how excited I am to be here today. I was so excited when Dr. White asked me to partner with her on this presentation. I said to her, I will take any opportunity to share with the department how impactful our peers are on the lives of our patients. So I feel really honored to be here today. And I also feel that it's very heartwarming to look around and see how many people are here today that are either our peers, supervisors of our peers, or people that work very closely with peers. So if you could raise your hand so we can look around and truly feel the impact of our peer workforce around the department. Wonderful. And of course, all our peers up here. So thank you so much for being here and supporting our peer workforce. So I'll just get started if that's okay. I'll just keep going here. So I want to just begin by acknowledging the peer history. So in the past 20 years, peers have grown exponentially across the globe. And we feel that here too in our department. The number of peers that we have has grown and grown and grown. And Dr. White's going to actually share about the history of our department, and you'll be able to see how that has transpired over time. Thank you, Sean. Okay. All right, so I want to begin by talking about what is peer-to-peer support. So peer-to-peer support is a range of activities and interactions between people who have experiences with mental health diagnoses and substance use disorders. And they really promote connection and inspires hope. And they offer this level of acceptance, understanding, and validation. And this may not always be found with other relationships with behavioral health professionals. And as I was looking through the literature, I found this quote, and it really stood out to me. It was very powerful as a way to really describe what peers do with our patients and how they approach their work with patients. And it's about being an expert at not being an expert. And that takes a lot of expertise, right? Do we agree with that, our peers? Yeah, is that kind of how it feels? All right. So really, they're coming from this more supportive rather than directive approach. They approach peers as more of like, or patients as more of a curious inquirer, coming from this not knowing stance, recognizing that as a peer, they are an expert in their own lives. Patients are an expert on their own lives, and they connect by sharing that with each other. Peers don't ever assume that they know everything that's right for a patient, but they are going to share about their own lived experience in order to help instill hope, inspire, and really make strong connections to build a lot of trust pretty quickly with our patients. I also want to identify here that peer support is conveying socio-emotional and instrumental social support in an interpersonal relationship. This is based on mutuality, empathy, and respect. And there's also this intention to bring about change. And that's something that is a major focus of the peer work. So I want to start by talking about how does peer support help? So the role of the peer support worker complements. It does not duplicate or replace the work of other therapists, case managers, and other members of a treatment team. Peer support workers bring their own personal knowledge of what it's like to live with mental health diagnoses and substance use disorders and also just mental health conditions. They support people's progress towards recovery. And they do this through three basic contributions of peer support. The first one is this installation of hope through positive self-disclosure. They also use role modeling to increase self-care of one's illness and explore new ways of using that experiential knowledge. So our patients come into our treatment and they have their whole lives of experiential knowledge. A lot of that, though, has been very difficult for them, devastating, debilitating. And the peers want to harness that, learn more about it, and help them shift that into more recovery-oriented language, how they can understand their lives in different ways and move forward in more positive wellness. And they do that alongside each other. However, in order for those two components to work, that nature of the relationship between the peer and the patient, those first two components must be established. Now, there's this wonderful graph here, graphic that demonstrates what does a peer support advocate do? They advocate. They walk with people on their recovery journeys. They dispel myths about what it means to have a mental health condition or substance use disorder. They provide self-help education and support people in identifying their goals and their hopes.
When we think about peer-to-peer support, generally speaking, it's ubiquitous. It's part of the human experience. And it really transcends any system boundary. When we look across our medical system, we find it in many other departments now as well. For instance, we can look within the NICU where there are parents volunteering to meet other parents and where our quality team is doing systematic reviews of the literature to learn about the impact that's having both on the health of the infant and the health of the parents in terms of reducing depression, anxiety, and increasing their feelings of competency as a parent, all of which we know create really strong, positive emotional futures for these children and their families. We can attend, for instance, the Monroe County Medical Society's forum in the spring and hear about wellness officers at Rochester Regional Health who are providing for doctors and other clinicians themselves peer-to-peer supports that will help in terms of reducing provider burnout and increasing well-being of staff. So it happens in the world, it happens across our system. What are those critical distinguishing features that we hear when we talk to our own peers and our own supervisors? It is a system of support. What are the roles, the key responsibilities, the resources, and the results that our peers say matter? So in speaking with our peers, here's a few things that they've highlighted, and also just to share with you how that's reinforced by the voices of our own patients in terms of quotes that were provided to our staff in Strong Recovery when they gathered up to 43 surveys as part of a wellness fair that occurred this fall. So peer-to-peer support is a role that provides hope and optimism. So we know from that survey that 88% of strong recovery patients surveyed felt that because of peer services, I feel more hopeful about my future. We also know that they're providing role models and reinforcement of individuals' identities, the meaning that they have and their purpose, including their goals for engaging with clinical services. So they say things like, we go out to meetings together. It keeps me staying in the program by being held accountable. We also hear how it is centered, as Julie was saying, on the instrumental and emotional support between the peer and the person seeking help. And here's a quote that our peers are building confidence in this person to go to AA meetings. We also know that it is based on this mutuality of the lived experience. And it really provides something very unique within our healthcare system. It provides this focus on the phenomenological experience. So that's a big word. What do we mean by that? In qualitative research, we understand that the subjective experience matters. The meaning that people make from their own point of view and having that shared with others is a powerful human experience. And our peer relationships center on that. They center on the meanings that our patients have, having these services be part of their life journey. Here's some quotes. This peer has been an amazing person to speak to, and she's very supportive and understanding. She's an amazing listener, and we connect in a friendship way. Sometimes I need somebody to talk to. So there it is, again, reflecting really that ability to share your thoughts and be heard by one another. Importantly, we also hear from our peers and our supervisors that these are relationships that are emphasizing really the core components of a recovery approach. And we'll talk a little bit more about that. But in particular, what we hear is that these are individualized meetings. So the person in care is really setting the directions and the goals of that encounter and that relationship. And here are some other quotes. Coming with a topic and working through skills to find out what works for me. My big goal was getting to refuge recovery, and I accomplished that. We also see that it's bringing out empowerment and really increasing the agency of individuals while they're in care services here. So here's another quote. She's helped me realize that no matter what, I'm a strong individual that can get through anything to reach my goals. And again, this is another strong recovery patient reflecting on the peer relationship. We also know importantly that these relationships is an experience of being mentalized or mentalization. Really, where in this interpersonal relationship, you can signal that we have this shared understanding that increases social trust, really is the foundation for all learning, and ultimately increases our epistemic trust, which is the ability to trust the information we're receiving enough so that we'll generalize it and act on it in our own lives. And so this ability to share between two people that I know that you know, that I know what's going on in your mind is very, very powerful. In fact, when we look also at other research, such as in 2015, when Neely Myers published this wonderfully written ethnography called Recovery's Edge, here she was studying what was happening when the first peer-led program came to a large community mental health center that was serving over 6,000 individuals that would be classified as having a serious and persistent mental illness. And this is in the post New Freedom Commission era, so in the early 2000s. And what she learned when comparing what was happening within this first peer-led services to other services is that she saw what was central to this model was this notion of moral agency, or as she defined it, a person's freedom to aspire to a good life in a way that leads to intimate connections with others. So, with moral agency, she found at the foreground, patients, rather than having to wait or defer being seen as a valued member of their community until they, quote, became rational, quote, became autonomous, or, quote, became employed or valued in some other system, they had, through peers, immediate access to unconditional social relationships and social acceptance. They were immediately recognized as a good person. They could be taken seriously for who they are now rather than who they may be in the future. And as Neely Myers reminds us, in marginalized and stigmatized groups, as we know, mental health has been and continues to be stigmatized, that these social relationships are essential to success and to promoting positive growth and development and having complete well-being as a person. So what do we see when we look at data from other surveys as well? We see that currently in the US, that we now have almost all the states are offering reimbursement for one-on-one peer services. And this includes peer services in mental health and also in substance use. And this is information that came out in 2023, utilizing data that went as far back as 2017. We also see that they're also offering reimbursement for, in this case, group services as well, but not to the same degree. So there are still many states, about 38, but less, that are offering these services. And so we know that there's still room for system improvement. So now we want to share also with you some history highlights. How did we get here? As Julie was saying, while the last 20 years has really seen an explosion across the globe of peer services, this opportunity that we have right now really stands on the shoulders of centuries of reform attempts and reformers who are patients and providers in terms of how communities address mental health burdens. So just to highlight a few things, and centering on just the 20th century where we saw a lot of changes. So, before the 20th century, what happened? So we know that, again, peer-to-peer support was really how mental health was addressed. So families in ancient and medieval times, from a Western history perspective, families and sometimes religious orders really were caring for and providing refuge for those with mental illness. For instance, in the Quaker religion, they exemplified aspects of this moral treatment, providing rest, this humanism, this respectful treatment and meaningful work, and really modeled this community integrated care practice that was based also on spiritual fellowship, peer-like support, where everybody lived closely and communally. But we saw then in the rise of the industrialization, a lot of isolation, goals to incarcerate, almshouses, institutionalization, and of course also the rise of the hospital movement in in the US and Europe. And that started leading to isolation from these natural relationships and healthy relationships. But that was really offset at the time by this mutual aid effort where unions, friendly societies, civic societies really provided collective support and welfare, where members themselves together meet the needs of each other for housing. Excuse me. In the early 20th century, we have individuals such as Clifford Beers, who, confronting these dehumanizing experiences in mental institutions really leads to the rise of the National Committee for Mental Hygiene and this mental hygiene movement that eventually evolves into the National Mental Health Association. We see also in the early 20th century, psychiatric leaders such as Harry Stack Sullivan, who, combats stigma and hires peers patients who recovered from psychotic episodes to staff inpatient units, and really conveying that mental illness is not permanent and institutionalization is not inevitable. Excuse me, thanks for the water. In the mid 20th century, we see the roots of the community mental health care movement come forward. For instance, with psychiatrist Eric Lindman, who shows how improved recovery occurs with local supports, provided in a framework for community-based care that would soon become this focal point of reform, deinstitutionalization, and community-based mental health treatment centers. We also see peers leading in addiction treatment and the rise of the Alcoholics Anonymous movement and the famous book that also continued to lead to other self-help movements, such as NAMI, being founded in 1979. And we see all of this occurring during the civil rights era and the recovery movement in mental health, and rising out of the disability rights movement that was also advocating for those with mental illness. We see in the 1970s the rise of the consumer, survivor, and ex-patient movement, where ex-patients were leading workshops with clinicians, such as encountering psychosis or everything you always wanted to know about madness, but were afraid to ask. They were emphasizing patients choosing their own course of the treatment, living fully and independently, and contributing to empowerment and self-direction models as the foundation of recovery-oriented programs. And then in the 2000s, we see this community support reform era continuing, focusing on services and communities for individuals with serious and persistent mental illness, really to be accompanied by natural supports to promote the quality of life. We see mutual aid efforts continuing. These are community-led efforts to close treatment gaps and fill in where systems fail to provide needed services, such as peer-led overdose responses, and also movements such as Black Lives Matters. We also see policy supports occurring, for instance, as our Center for Medicaid and Medicare Services provides guidance to states interested in peer support services in 2007, which then leads to the 48 states, as we've seen, being able to reimburse for peer services for mental health. So what's happening in our department and in our area when all this is going on? And again, this is going to be incomplete because these are just some highlights in speaking with individuals who have led during this time, such as Marilyn Guadagnino, Eric Kane, Steve Lamberti, and also Caroline Nestro, who I want to thank for informing this slide. So Eric reminds us that in the 1970s, our chair, Harut Babigian, stands up a crisis call line related to psychiatric emergencies for our community, the first one that eventually the Mental Health Association takes over. We also see in our community Bernice Skirbel, who develops Mental Health Association's Adopt a Patient program into a community-based mental health support program now called Compeer. Excuse me. In the 1980s, Steve Lamberti and a resident with a psychosis diagnosis embed peer supports and build relationships with community-led peer support organizations. We see our staff who are seeing peers helping one another for the first time in our partial programs in the groups that are being offered. And as Caroline reminds us, she says, it was the first time I've seen how a therapist, how a peer could provide, excuse me, better than how a therapist could help them. That was my first introduction to the power of peer relationships in recovery. In the 1990s, our peers are becoming CASAC workers who speak from personal authority of the lived experience. We see our patient councils really burgeoning at the medical center that includes members of peers as members. And then we see even in our local community, our efforts really grow internationally, and CompTIA establishes its first international affiliate in Sydney, Australia in the 1990s. In the 2000s, our clinical leaders such as Hope Qualo and Joy Koziel and Marilyn Guadagnino established a peer specialist program with certification training, all within Strong Ties. And our Department of Psychiatry Advisory and Council of Consumers, affectionately known as DPAC, starts with system advocacy and improvement in 2006, led by Glenn Palmer, Patrick Sesh, and Caroline Nestro. And members really, they were called forward to be advising on ambulatory services. But at the first meeting, they said, no, we're okay with that. We want to focus on CPAP and we want to focus on inpatient. And quickly that becomes an advisory council for the whole department. After a brief hiatus, the Office of Mental Health Promotion restarts DPAC and sustains it as a model. In the 2010s, we see Strong Ties is downsizing from its peak of 20 peers when it was running over 30 groups a week, one-on-one peer counseling. Peers are providing RAP training, offsite support, and even having 3 peers on 4-9,000. 3 peers stay on in ACT and in care management. Tony Akabuchi, he's the last one who leaves by 2018. And 3 returned to Strong Ties in 2015 when we start our CCBHC programs. Excitingly, in 2010, Mobile Crisis has a full-time family advocate. We see community health workers also, individuals with incarceration histories, providing services through programs led by Diane Morse as the WISH Transitions Clinic. And we have more system advocacy, even passing around buttons to our clinical leaders that says, what would DPAC say? So clinical leaders remember to come and ask our consumers first, not wait to report out what happened, but come first and really change the culture of how we make decisions. In the 2020s, our CAC-BHC expansion occurs with more service line integration, peers across psychiatry. We also see that just before COVID, our DPAC members actually draft the first job description for our CPAP family peer. And of course, Julie is named our first discipline chief in 2025. So what do we know? Our data is a little limited right now. Christy Stockwell reminds us that for the first time, we actually have some Press-Ganey scores in CPAP that are tailored to peer services. That just started. And what we know from eight surveys that were provided is that, and these are quality ratings of patient satisfaction, often reported as the highest levels of satisfaction. So we see that most of these individuals are reporting the highest levels of satisfaction with our peer services. That includes such things as courtesy, overall care, feeling listened to, and being concerned about comfort. We also see that our peers are drivers of quality as part of the care team. Importantly, right, we see in comparing our patient satisfaction with many members of the care team in CPAP that they are driving. They're the first bar we see here, peer support specialists, followed by crisis specialists, nurse practitioners, directors, and clinical staff overall. These are very high numbers, and we are not able to compare to benchmarks because actually they don't exist for CPAP services.
Thank you, Dr. White. So in the interest of time, I'm just going to go through these slides pretty quickly. We've been hearing about how there was a survey given to strong recovery patients, and really overwhelmingly, the results were positive about the services that they receive. I also want to note that this is raw data, so there could be discrepancies, but just still would like to highlight that some of the responses about how peer support specialists help them to feel understood and supported. So feeling so that peers are approachable and understanding. They listened to me. There was no judgment. They listen and give great feedback. We go for walks. We go out for coffee. It's a great experience. Also, that there's always areas for improvement, and these type of patient surveys help to provide us with experiences to learn from and grow. So as always, Meliora. I Again, what I want to just highlight about this slide is that the survey asked about a positive experience working with a peer or a case manager. And this person said, let's discuss both. It's difficult to discuss one without the other due to the greatness that both bring to the table. So it really shows how peers work hand in hand with other members of their treatment teams, multidisciplinary teams, to provide holistic and comprehensive care to our patients. With essential responsibilities, peers are skilled at engaging with patients and they gain a deeper understanding of their lives and their needs, and then sharing these assessments with the multidisciplinary team. Patients may feel more comfortable with a peer. They may share more with a peer than they would with other members of their treatment team. And then the peers can relay that information to the team. So they do wonderful work with engaging patients and then engaging into the care teams. So in our department, we have 3 different kinds of and types of peers that have specialized training and certifications. We have our mental health peers, also known as certified peer specialists, substance use disorder peers, known as certified recovery peer advocates, and certified addiction recovery coaches. And the 2 of them, and depending on the person's lived experience, they may have co-occurring experience themselves, or they may just be pulling from their experience with a mental health diagnoses or a substance use diagnoses to help support in seeking and maintaining recovery and overall wellness. We have our family peer advocates. This tends to be a trained parent or caregiver who's navigated the child serving and behavioral health systems. And so they really help to build that connection between the treatment that's happening within the clinic and then out into the community. Oftentimes with like schools or other entities that can help to support the family and the loved one. So we've talked a lot about what peers are and what they do. And I think it's important just to state, does this work make a difference? Well, yes, it does. A lot of literature shows that peers make an incredible difference in the lives of our patients, including reduced relapse rates, increased treatment retention, increased rates of post-discharge participation and retention, decreased substance use and depression, and also higher drug-free rates at 6 months. And you can see the list goes on and on. I want to take a moment to acknowledge all of our supervisors across the department. We have Marilyn Guadagnino at Strong Ties, Gerard Johnson at Pediatric Behavioral Health and Wellness, Tyler Buchero at Older Adults, and Danielle Altamira at Mobile Crisis. Many of these people are in the room today. And then we have Casey Healy at Strong Recovery and Anna Kedley, who supervises CPEP peers, peer bridgers, and our peer at G92. Both of them are our moderators today for our panel. Also, these are our incredible peers that are located across the department. And there's no better way to recognize them than to highlight this video that was made for Global Peer Support Day. And the supervisors were able to share about the vital work that our peers do from their perspective. Okay, I also want to share that, oh, yes. I also want to share too that we have our family peer advocates too that are located in our pediatric behavioral health and wellness locations, and we have 2 of them today. So we're excited to have them join as well, but we're going to have the panelists introduce themselves and have our moderators come up. We'll transition into the panel part of our presentation.
Great. Thank you guys so much for all that information. We want to open it up to our panelists now to share a little bit about their lived experience. So we have some questions that we prepared, and if there is time after, we will open it up for questions that you may have. So the first question is, what is unique about the practice of peer specialists? And can you share a story that illustrates this approach? Whoever wants to go first.
My name is Mike. I'm a recovery peer advocate at Strong Ties and a certified recovery peer advocate. But so I've been with the company for about 3-4 months now. We have that unique opportunity to really meet people where they are. We speak to them about like the smaller things when their providers or counselors, therapists speak to them. You got to get through a list of things to do. You got 4 different forms you got to fill out. You got to send out emails. We can kind of kick back and talk about what's your diet look like? What's your sleep look like? What do you do in your spare time? We had a patient who'd been client with us for quite some time, had gone through a transition, was moving from supportive housing to a more independent housing, had lost a lot of supports and nets. I was able to go over to his house after everything was moved in and just kind of help him organize boxes, have a familiar face in a new space. And, he was beaming very brightly. And, the place looked much better. And just to be able to have that time and that freedom to be able to go meet him where he was and have that comfort and rapport.
Good afternoon. My name is Jaleesa Johnson. I'm a family peer advocate over at East River Road. I would say what's different about or what's unique about this practice is I'm able to take everything that I've been through in life and sit with people who are going through it and tell them that there's a way out, that there's answers, and that there's also people there to support. It's really hard to pinpoint a specific story about families, but I can say that I've been working with one family for about 7 months now. And just to see the evolution of the family and the dynamics change with a little bit of support behind them has been absolutely beautiful. I've got a mom who's dealing with some special education services that are needed and just really not having the school support them. And to see mom in the beginning be all frazzled, have no idea what to do, go from that to, getting her daughter the supports that she needs, but also helping other families within this the school system has been wonderful to see. So, yeah.
So question number 2, what outcomes or benefits do you witness among patients, providers, peers, and programs?
I think I can speak to this a little bit. Okay.
Maybe one more time.
Okay, I got it now. It's working. I'm Christine Coco. I'm a peer support specialist and family advocate at Strong Ties. I've been here about 6 years. It has been a real pleasure getting to know my clients and being able to help them to instill hope in them when it seems that all the lightness is gone. I think what's most important about the benefits that I've seen with them is that some of my clients have shared some of their deepest, darkest secrets, some of the most intimate details about where they have been in their life and what they've gone through. And some of the times they won't even share this with the regular therapist. And I think that's saying something, that the trust is there to kind of build that relation and that rapport with them. And just knowing they have someone to trust and someone to listen to them and to share that hope with them.
I'm Melissa Charchalis. I'm a family peer advocate with Mobile Crisis. I would say that the benefit is faith in the system. I think parents especially are so overwhelmed, especially in a crisis situation, that they are just, questioned, and you're reliving the story over and over again. And you're kind of like, okay, what now? And heard several just say, I've had it with this system. I want to give up. I don't want to go back. And I think having someone that's also gone through similar experiences is so helpful. And they see, okay, there is a light at the end of the tunnel. Maybe this is the avenue we need to go. So just like I said, just having faith that these things, it works. It's just, sometimes they're just so overwhelmed with different providers giving a diagnosis, or just making sure the child's, or whoever a patient is doing okay, that a lot of times the parent or family gets overlooked in that moment.
My name is Chastity Phelps, and I'm a family peer advocate at South Avenue. And I feel like the benefit is working with the families and teaching them to become self-sufficient so they can advocate for themselves.
Thank you. Very wonderful to hear the impact that you guys have with patients and your ability to kind of walk alongside of them. Our last question that we prepared is, how do you see the practice and practice system changing in the future, and what changes are needed to help sustain these efforts?
I guess what I would say is, I think that for being a peer and being in this role for the past 6 years, I've really grown as a person personally. And I think having those extra leadership opportunities that are available to me as a peer, that might look like maybe teaching a class on peers, or doing seminars, or running professional development for those who are interested in becoming a peer specialist, or those who are needing that extra help that they need to get to what they want to desire, to feel better and to feel not so stigmatized. So again, I think it's the leadership opportunities that are available that can come from these positions.
Sorry, I just want to add something that I think this should be becoming the norm, not just an option. I think that it's underutilized, and I think that the more staff is trained on this and understands that what it is exactly that we do, is just going to provide way more opportunities across the board.
I just want to piggyback off of what she said on that, because I think also getting more data, obviously, data is just now being collected. I'm very big on data. I think, putting out more surveys for families to see what the benefits have been and kind of what their journey in the beginning looked like, kind of like pre and post survey type of thing. I also think, and this might be a little controversial, just kind of giving the family peer advocates and the peer specialists kind of the room to speak on these things, to bring us into the room, to have us kind of speak on what our families, but also to give the families opportunities to come in and speak on what they've seen through this. Obviously, having opportunities through the URMC is amazing, but I think bringing families in to speak about their experiences is kind of like the next, I'm hoping is going to be the next shift. I think COVID has really taught us that having people around is the most important thing. And when you're going through things, speaking on what you're going through makes you feel okay in that moment. So I think, just bringing those families in to speak on their experiences would be number one.
And I think that, right now, that's awesome. Also, to kind of piggyback just an extended growth of it is a like continued collaboration between peers and the providers, the counselors, the therapists. I often find myself in a position of, I had a medically assisted treatment, right? And so if I have a client that's interested in that, I can have, a provider can kind of call me in the room. I've sat with other providers and spoken on behalf of like medications, my experiences, challenging the stigmas around them. A lot of times I feel like a fox in the hen house. I have just gotten out of a meeting with a counselor, and now I'm sitting down with my client, and, we are working on a plan together with John. But, John might not know that we are as closely connected as we are and working towards this common goal. So for the counselors and the therapists to recognize that we kind of got an in, and you can use that, to hopefully leverage better outcomes. I think that closer collaboration between the peers and the rest of the care teams is really where it's at.
Thank you, everyone, for those very thoughtful answers to these questions. We'd like to open it up to questions from the audience.
Hi, great presentation, and so excited to hear from all of you as panelists. I'm at East River Road, and I have loved getting to work and really plugged to families to work with you all. And so something that comes up frequently for patients and families that I have heard is this idea of like the thought of having to meet with another person. So I'm just wondering from you all, like, what's a good way that we can sell it? Because I know sometimes that overwhelm can be a barrier to getting their foot in the door, and can kind of, I think like getting there is then when they see like oh, this is a great opportunity, but sometimes it's the getting there that can be hard.
I think what's important about this is being a peer in this position, that kind of selling the idea of peers is that we can meet with them in the community, we can go out for coffee, we can go for walks. I think just having that less pressure of being in a position of just being in the office and going for an appointment, just having those community opportunities to go out. Like, for example, I've gone to the mall with my clients. I've taken them on walks. I've gone in different places, coffee, Dunkin' Donuts. I think just kind of selling it to them that, it's there for them to keep, but in a friendly sort of way, but not to scare them in the sense of that's just another appointment.
I more so think of it as looking at their care team as a collective, just helping them figure out what their goal is for their health and what they want to see done. If they are navigating multiple providers, helping them do those case reviews where all the providers are in one room or all on one telehealth visit or Zoom, so that they can come to a common goal to help them navigate all of those providers. Instead of them having multiple appointments, everyone is in one room as a collective, helping them figure out what the common goal is.
And just to kind of add on that, I think also integrating peers from the orientation and right from the beginning and introduction of the peer support and how they can assist patients and provide support to patients is critical.
I just want to add one little piece into that because, Rachel, I'm in the same location as you. So I think within our clinic, it might be a little bit easier to kind of do a warm handoff during the appointments. So, when kiddos with you, kind of set it up as in like, hey, mom, I know you've got some downtime. Why don't you go meet with our family peer advocate? And we can just kind of make it more of like mom and I, or dad and I, caregiver and I, and then you're able to focus on kiddo. So maybe utilizing that time to get that.
You've already started to answer some of my question, but I'm wondering, what can we as your peer employees do to better support your integration into our teams?
Oh, I feel like just understanding what our role is and what we do, and to think outside the box, where it's not just them, if it's not just with their care, if it's something that's going on in their personal life, if it's them having trouble navigating systems, to understand that we can help them as well do that. Finding community resources, things as a whole, like not just wrapped around just their care.
Yeah, I think for me in particular with family support, it can be confusing because you hear that and you're like, oh, is this family therapy? Or so I think having the team kind of, like you said, recognizing what your role actually is and kind of reiterating that with who you're working with, and just letting them know that this is support for you. This is to help you get through this. This is just another person that is on your side, more than another person checking through the boxes,
Hi guys, I'm an internist or doc of internal medicine, working on G92 and 192 with the incredible Ariana, our new peer, 6 to 12 months, I'm not sure, but it has been such a gift to have her on the team doing really difficult work for really vulnerable populations who are not just up against so much physically. Most of our folks have complications of injection drug use, up against so much psychologically, medically, but also up against a fractured system. And while UR has done such a great job to kind of build out that system better and better, gosh, the bar is real low in the United States. And I know that as a doc, and I also know that as a family member who's watched, gotten the best medical education I got was watching family members try to navigate the same, right? Being incarcerated for psychosis, struggling to find employment while working on stimulant use disorder, remains the best education I've ever gotten. So I think this is just so essential. And what I will say is that I noticed that the satisfaction scores for the docs was about the same as the peers. So shout out peers. And I would also go further to say that, you know, when we push for data, I want to be careful to just say that, gosh, I think half the credit I get from patients is built off the teamwork of patients. When I get UR stars, oh man, I felt so heard. That's in collaboration with other people who are giving me that alley-oop. And so I would go further, kind of mentioning the survivor researcher movement, or the consumer user survivor researcher movement. Folks like Nev Jones out of Pitt are starting to kind of say, gosh, we don't just need you at the bedside, we need you doing the research with us. How can the academics in the room not just include you at the bedside, but help elevate our research efforts too? Like community-based participatory research, maybe thinking about how our pipelines can be more supportive, less ableist, all that jazz.
I would say that we should be including lived experience as experience and bringing those people to the table. I think that's the number one, including the families, including the peers in this. Now, obviously, I don't want to say, trying to find my words exactly with the clinical aspect of things. So basically what I just want to say, I'm just going to completely just say it as I'm a person. I know that my lived experience is just as important as a degree is. And I think that once we bring that to the table and we can shed light on that, the data will change as well. I don't know if the right people are in the room when it comes to the data. And I didn't know how to say that. Hopefully that came out the way intended. There you go. Exactly.
Are there any other questions? Okay.
Well, that takes us through the program that we had planned for today. We want to thank all our panelists, our moderators, all of you for the amazing questions. It sounds like it really is, hopefully is going to start some really important conversations back in your units around this integration with research as well. How can we continue to bring the voices of the lived experience forward in driving and hopefully that we can continue to rise and raise the data that is available so we can continue to improve our system around that.
Yes. Thank you so much, everyone. Great work.